Everybody, and welcome to our final IOPPN at Twilight lecture for this term. My name is Juliet Foster. I'm Dean of Education at the IOPPN, and it's my great pleasure to be chairing this session this evening. Now, just before I introduce our speaker for this evening, Professor Katja Rubia, and her talk, I do just want to very briefly thank everybody who's been involved in producing and putting on this IOPPN at Twilight lecture series over the past few weeks. I think it's been hugely successful, and we've had some fantastic lectures and really great attendance from our staff and students. And obviously, I'd like to thank all of the speakers and all of the chairs, but I'd particularly like to thank everybody who's made this happen behind the scenes. So I'd really like to thank Trevor in IT, Jonathan, Hannah, Louise, Jazz, all of the comms team, everybody who's worked so hard to put these lectures together. It's great that we've been able to record them, and obviously they'll be a really great resource for the future as well. So again, we're recording the lecture this evening, so please do bear that in mind. And once we get started, please do remember to submit your questions via the live event Q&A at the side of your screens, and also in addition to putting in your own questions, please do upvote questions as we'll read out the ones that are the most popular with the most votes towards the end. Anyway, I'd now like to thank our speaker this evening, Professor Katja Rubia, for giving her time this evening to come and speak to us. Katja Rubia is a Professor of Cognitive Neuroscience at the IOPPN at King's College London, and her key areas of expertise are neuroimaging of cognitive functions in normal development, structural and functional neuroimaging of neurodevelopment disorders, most prominently ADHD, ASD, OCD, conduct disorder, and childhood maltreatment. Pharmacological imaging of ADHD drugs and of neurotransmitter manipulations, PET imaging in ADHD adults, and neurotherapeutics such as real-time fMRI, neurofeedback, and non-invasive brain stimulation combined with cognitive training in ADHD. Katja Rubia received the European Kramer-Polno Prize, KPP, in 2013, given for scientific excellence in clinical research in biological child and adolescent psychiatry. And in 2019, she was elected corresponding foreign member of the Royal National Academy of Medicine of Spain, which is given to internationally renowned academics who've contributed to the field of medicine. So thank you so much, Katja, for offering to speak to us tonight. I'm going to hand over now so she can begin her lecture on neurotherapies for ADHD.
Thank you very much, Juliet. It's a pleasure to be here for the last lecture of the year. And what I will tell you a bit about is about brain therapies for ADHD, where we are in the field. So I will first of all tell you a little bit about the brain function abnormalities and structural abnormalities in ADHD. Then I will have a little digression. I will tell you about brain plasticity, because I think the most revolutionary finding of the last 2 decades of neuroimaging is the knowledge and the insight that the brain is far more plastic than we thought before. And that had really enabled brain therapies and really made it possible that we can now change the brain of psychiatric disorders. So just to say a little bit about ADHD, if we go into the history of the disorder, the first person to mention ADHD was Melchior Adam Weikart, a German physician. He was a professor of medicine, and he was also the court physician of Catherine II in Russia. And he describes a group of children who have poor attention and are easily distractible. He says they have jumpiness, which is now called hyperactivity. He also refers to restlessness, imprudence, which now is more called risk-taking behavior, inconstancy. He also already mentioned that this is a disorder which has an early onset and disturbs learning at school. Alexander Crichton, 3 years later, was a Scottish physician, and he also described a group of children who are incapable of attending with a necessary degree of constancy to any one object. He also interestingly mentioned mental restlessness, and only recently there has been a lot of research showing that ADHD patients have more mind wandering. So this is rather interesting that that was mentioned that early on in 1700s already. He also said these children are easily distracted by external objects. They have lack of mental energy to attend, which refers a bit to what we now call arousal problems. He also mentions fidgetiness. And later on, the German physician, which is a bit more known, at least in the German culture, Heinrich Hoffmann, he published a very famous children's book where he described many mental disorders called Struwwelpeter, and he described fidgety Phil, in German Zappel-Philipp. And this is a boy who doesn't listen to his father, is disobedient, and moves too much, and ends up tearing down the dinner table because he's hyperactive. He describes, interesting enough, another type of ADHD, and what we now call ADD only, without the hyperactivity. So this is Johnny Look into the Air, who is a type of inattentive boy who is distracted. And because of the distractions, of course, he then falls here into the lake because he's distracted by the birds. Sir George Still was the first British pediatrician who focused a bit more on the emotional regulation problems of ADHD patients, which have been widely neglected and only recently received more attention. So he already in 1900, he called it the disease of moral control. He focused on problems with delaying gratification or failure to control emotional activities, which we now call emotional dysregulation, little control over behavior, and he also mentioned problems with sustained attention and not considering consequences of acts. So this refers very much to problems with forward thinking, temporal foresight, which is mediated also by the frontal lobe. Franz Kramer and Hans Pollnow in 1932 are German physicians, and they describe very much the hyperkinetic disorder as we know it today, with features of hyperkinesis, inattention, and impulsiveness. Now, ADHD, as you can see, has not just since the 1800s, has been very widely depicted in cartoons, because children who are disobedient, a bit naughty, and hyperactive seem to be, funny for other children. So the most famous cartoon and more modern cartoon is Bart Simpson. So he has conduct disorder, he has ADHD, and he's also on stimulant medication. So now ADHD in the DSM-5 is defined as problems with age-inappropriate, persistent, and impairing symptoms of inattention and impulsiveness and hyperactivity. So when I started working in ADHD in the 90s, there was still very prevalent this view that these children are just naughty children who suffer from poor parenting, and evil doctors give these children medication when a little bit of discipline would be sufficient. So unfortunately, this is not the case. And if you've ever seen a severely hyperactive child, you will realize that this is not just a case of naughtiness. They really have a problem, and these children suffer from it. And even in adulthood, they still suffer from problems with attention. They have often anxiety and depression because of a lifelong failure in academia, in academic achievements, and other problems like substance abuse. So I think we were one of the first to image ADHD children in the 90s, and we have contributed to the view, which is current now, that ADHD is a neurodevelopmental disorder. And we know now that ADHD children are suffering from having a delay in brain maturation, in the function and the structure of the brain, and their brain abnormalities, as I will show you later. So ADHD is one of the most common childhood disorders. 1 in 14 has ADHD. So if you have a classroom of 30 people, you may have on average 2 children with ADHD. And as I said, in adulthood, mostly the inattention persists and impulsiveness. The hyperactivity may grow out more. It runs in families, there is heritability. It is thought that there are multiple genes with small effects, but there are also environmental factors. Early adversities in childhood can be related to ADHD, parental discord, obesity in mothers, or lead poisoning, preterm birth. All of these can be related to ADHD. It's probably an interaction between gene and environment, as in other disorders, and it is more prevalent in boys than in girls. Most children respond very well to stimulant medication, so 70% respond to and are often treated with stimulant medication, which improves the symptoms. It doesn't normalize them, so it's more like a care than a cure, but it's a very good drug with relatively small side effects. So at a cognitive level, these children have low IQ, they have problems with learning at school, and the most consistent problems they have, if we try to split it down into different cognitive domains, they have problems with working memory, which means holding information online. They have problems with inhibitions, with self-control, inhibiting distraction or inhibiting a motor response. They have problems with attention, especially sustaining attention, which means problems with concentration, as we already heard described by the very early physicians who described ADHD. This is definitely a key problem. And also they have problems with timing, and timing is very closely related to impulsiveness. Because if you're impulsive, you do things prematurely, too early in time, without considering all the consequences of your acts, which means you don't look into the future, you have problems with forward thinking, temporal bridging. And children with ADHD have also a problem with waiting behavior. And there's evidence that if they estimate time, they overestimate. So time seems to be subjectively elongated. And that might be related to the problems they have with waiting. And they have problems in tasks where you have to choose a small reward or a larger reward later. They're more likely to go for the small reward now because they live more in the present. So there have been hundreds of fMRI studies, and we have also done many, but more recently we have tried to summarize the findings and to try to find the most consistent problems in the brain function in ADHD by doing meta-analysis of all the available studies so far. And what we find is that in meta-analysis, where we pull together all the imaging studies, where people have looked at the activation in ADHD and in contrast doing tasks of self-control, of inhibition, we find they have reduced activation compared to controls in this right inferior frontal region, which is a key area of self-control, and the basal ganglia. So the frontal lobe and the basal ganglia, they form these frontostriatal networks. And this is particularly a network for self-control, which is underactivated, not activated as it is in controls. And we've replicated these findings in 3 meta-analyses, so it's the most robust finding in the literature. Another area which is impaired is a more dorsal region, the dorsolateral prefrontal cortex, again together with the basal ganglia and the parietal lobe, which is important for attention. So this area is particularly reduced in activation doing tasks of working memory or tasks of attention. And doing timing tasks, they have reduced activation in the cerebellum, which is a key area of timing, again the infrafrontal cortex and the parietal lobe. So this is a frontocerebellar network that is important for timing. So these frontal regions, which I've just showed you, the dorsal and the inferior frontal cortex, the basal ganglia and the cerebellum are the latest regions to develop. So many people know that the frontal lobe is the latest region to develop in the brain, but the basal ganglia and the cerebellum are even later in development, and they all develop together late in adolescence, and they form networks. So the brain, of course, always works in networks, and they form networks called frontostriatal frontal-basal ganglia networks or frontocerebellar networks. And these networks mediate those functions which are impaired in ADHD, like attention, forward thinking, planning ahead, timing, and self-control. Now, if you now look at the blue regions here, so these are areas which are overactivated in ADHD compared to controls. And this is an area, the posterior cingulate, which is part of what we call the default mode network. And this is called default mode because it's activated when you do nothing. And when you do nothing, what you do is your mind wanders, or you have random thoughts. And typically when you want to focus on something, or you attend to a task, you need to switch off your mind wandering. So for example, if you want to understand what I'm saying in this lecture, you have to switch off your mind wandering, and you have to switch off thinking about what you're going to cook for dinner tonight, or where you're going to go out, although you can't really go out because everything is closed. But basically, when you focus and you concentrate on a task, you have to switch off your mind wandering. So this process develops with age. So children have a lot of mind wandering, and the older the child, the better able to switch off the mind wandering, doing cognitive tasks, doing attention tasks, and so on. So in ADHD children, they have problems both with switching on these task-relevant networks. So just to show you, so this in particular, the medial frontal cortex and posterior cingulate are key areas of this mind-wandering network, which lies in the middle of the brain. So ADHD children have problems switching off their mind-wandering network. So when you do attention tasks, for example, you have to switch on these blue regions, which lie in the lateral areas of the brain, and you have to switch off your mind-wandering network, which lies in the middle of the brain. So ADHD children have problems with switching off the mind-wandering network, and they have problems with switching on those attention regions. And both of this is related to poor performance in tasks, in cognitive tasks. And these two networks, of course, typically need to be are anti-correlated, because the more you switch on task-relevant networks, the more you have to switch off your mind-wandering. So they're normally anti-correlated. And in ADHD, they're less anti-correlated. Now, if we look at the structure of the brain, so everything I've told you so far was about the function of the brain. You can think of it as the software of the brain. What about the hardware? So the structure of the brain. And again, there have been hundreds of MRI studies, and I won't show you all of them, of course. But the Enigma is a really good effort where people are pooling together imaging data all across the globe in all psychiatric disorders, or most of them. And we are part of this ADHD working group, which is the light blue. So if I show you just the ADHD working group, so we've collected imaging data from Australia, from China, Russia, from Northern Europe, from North America, Europe, all of Europe, not just Northern, from America, from Brazil. And we had data from over 4,100 ADHD children and adults and controls over 38 sites. And what we find is they have these children and adults with ADHD, they have indeed abnormalities in the structure of the brain, most pronounced in the basal ganglia, which are of course also the same areas which are reduced in function. In the frontal regions here, the parietal lobe, which is important for attention, and the yellow areas here is the default mode network. So the same areas which are not functioning well are actually smaller in structure. And the differences are small, between 2 or 3%, and they're most pronounced in children. But although they're small, they are there. So there is a brain correlate to ADHD. So these are not just naughty children, they have some abnormalities in their brains. So in conclusion, ADHD children have problems with several frontal regions, the basal ganglia, the cerebellum. There's some evidence for some limbic areas to be impaired, which is probably related to emotion dysregulation, but the evidence is less strong. And they have problems with the mind-wandering network, which is overactive, and they have decreased anti-correlation between these task-relevant networks and the mind-wandering network, which in normal adults is nicely anti-correlated, but less so in ADHD. And there's evidence that all of this is related related to delay in maturation. So there's evidence that ADHD children have a 3 to 4 delay in the maturation of the structure of the brain, and they have a delay in the maturation of the function of the brain. So their brain structure and function pattern is like that of younger children compared to older children. So, of course, when we think of brain therapies, the easiest areas to modify are the frontal regions. And this is because they're more accessible. So for brain stimulation, for example, you can only really modify those frontal areas like the infrafrontal cortex or the dorsolateral prefrontal cortex. And these regions have been modified with brain modulation. With neurofeedback, for example, you could potentially target deeper regions like the basal ganglia or the cerebellum even, but it is easier to teach people to self-regulate frontal regions. So that's why most neuromodulation techniques so far have focused on those frontal regions. And as I said before, the areas which have been mostly modified with brain stimulation, for example, is the dorsolateral prefrontal cortex, which I showed you is important for attention, for working memory, and underactivated in ADHD doing those attention or working memory tasks. And the infrafrontal cortex, which I showed you, is the most replicated brain underfunction in ADHD. We found it to be underfunctioning in 3 fMRI studies. So the last one we had more than 1,000 ADHD children and 1,000 controls. And as you know, in science, you have to replicate your findings, and the more you replicate it, the more robust. So this is very, very replicated. And this area here is very important for self-control, for attention, and it's also important for timing functions. Now, we also wanted to investigate what stimulant medication does, because stimulant medication works so well in ADHD. So given it works so well, we thought it must have an effect on those areas which are not functioning so well. And we did, in fact, indeed, we found that stimulant medication most consistently enhances the activity of the same right infrafrontal area. And of course, this could explain why stimulant medication is so good in improving, especially school performance. It improves attention, it improves self-control. And it could, of course, be because it has an effect on this area here in the brain, which is important for concentration. It is important for timing, impulsiveness, and it is also important for self-control. So if we would modify this region, we thought we could then mimic the stimulant effects, but without the side effects. Given that, of course, the action of stimulants is precisely upregulating this area, can we upregulate this area with neurotherapies and then achieve the same effect as with stimulant medication, but without the side effects these drugs have? And just to go a bit a step back, why do we not just stick to stimulant medication? I've showed you that before, I've said before that it's effective in 70% of patients. In my view, it's one of the best drugs, if not the best drugs we have, the best drug we have in psychiatry, because the effects, the side effects aren't that bad, then aren't as as severe as the side effects of antipsychotics or antidepressants. But there are, of course, still some side effects. There's evidence that stimulant medication can stunt the growth, they can reduce the appetite, the weight. Some children have abdominal pain. It can disturb the sleep. It increases hypertension. And of course, parents do not want to give their children drugs which can cause side effects. And not everybody tolerates it sufficiently. And I think the most important limitation is that stimulant medication have shown to work really well if you test it over 6 weeks, 8 weeks. But studies that have looked at longer effect have found very little evidence that there is longer term efficacy. So the effect may dissipate. And we've shown that in the brain, there is an adaptation to stimulant medication. So the brain adapts to the drug, and that could explain why it doesn't work long term. So if it doesn't work long term, then it will be good to have an alternative treatment, and also parents and children prefer non-pharmacological treatment. Unfortunately, most other non-pharmacological treatment like behavioral treatment, cognitive training, exercise have shown very small effects of improving ADHD. So brain therapies could potentially have a good effect because they're very targeted. We spent 3 decades imaging the brain of ADHD children. We now know which areas are not working well. So there is, of course, the logical conclusion would be, now that we know which areas aren't working well, can we increase these areas with brain therapies where we just directly target these regions? And brain therapies have very minimal and transient side effects. And there's evidence that they have longer-term neuroplastic effects. And of course, drugs cannot offer longer-term effects, especially stimulant medication washes out in 24 hours. And a good colleague of mine, Jeff Newcomb, calls it the Cinderella effect, because you only have so and so many hours where you're going to be able to concentrate and control your hyperactivity. And then when the drug wanes, which can be already after 8 hours, then you need to make sure you do everything you need to do in this time, or take another pill. So the drugs do not work long term. And this is, I think, the biggest attraction of drugs, that of neurotherapies, that there's some evidence they may have longer term brain plastic effects. So if you train a child to self-upregulate some areas, that may work for longer than a medication. Now I want to do a little digression and tell you about brain plasticity, because I think over the last 2 decades of neuroimaging, the insight that the brain is extremely plastic has been, I think, the most revolutionary insight, and it really enabled, it made it possible that now we think that the brain abnormalities we see in psychiatric disorders aren't permanent and they can be changed. And this is only really thanks to our insight that the brain is plastic, and you can change a brain and you can change the behavior that the brain. So there is mind over matter. And I want to show you some example of brain plasticity. The most striking one, my favorite study, is the study of Bogdan Dragansky in Nature, published in 2004. And what they did is they taught normal people, business people or random guys, to juggle for 3 months. So, and these people had never juggled before, and after they learned to juggle for 3 months, areas in the parietal temporal visual motion processing regions, they became larger. So areas that process motion, which is related, of course, you need for juggling, they became larger after 3 months, as you can see here. And then they were asked to stop juggling, and after only 3 months, the brain regions went down again. So this really was quite revolutionary, because in the 90s, when I started working in neuroscience, it was thought that the brain in adults doesn't change. In childhood is a bit more plastic, but it was thought that in adulthood, the neurons you have, that's what you have to live with. And it was thought the brain only changes when you have a lesion in the brain, or when you age, and other than that, there is no change. So this is not the case. So this study really showed that learning can change the structure of the brain. And more relevant to you, if you're students, they did a study a few years later where they tested students in Germany who have to study for 3 months in the middle of their medical career for a very tough exam. And after 3 months of intensive studying, they found the parietal regions increased in structure, and the hippocampus, and this is an area for attention, and the hippocampus is important for memory storage. So, which is good news for you. Even if you don't pass the exam, it doesn't really matter, because when you learn for an exam, you actually change your brain in a positive way. So you're actually working on your brain development, you can say. You may all have heard this study that London taxi drivers have larger hippocampi, and this is because they have to learn 20,000 street names and thousands of places. And interesting enough, the posterior hippocampus, which is important for memory storage, is larger, but the anterior hippocampus is smaller, and that's important for learning new visual spatial information. So there is a little cost where the back of the hippocampus becomes larger, but the front becomes smaller, and that has some possible negative effects. Now, there's of course a lot of studies have shown that meditation can change the brain. We have done a few studies on meditation, and we find that people who have meditated for more than 5 years have 77% larger grey matter, which is actually quite a lot, much larger than the differences usually between psychiatric patients and controls, in regions of emotion control and of attention, and they have younger brains. So the normal age-related decline, the grey matter goes down with age, is less pronounced in people who meditate. So you could say meditators have younger brains. There's of course also what I call negative plasticity, and a good example for negative plasticity is childhood maltreatment. So children who have been abused, and even if they then grow out into adults, have differences in their brain structure. And we have done several meta-analyses of all these studies done in people with child abuse. And we find that people who have been abused in childhood have smaller volumes of the orbitofrontal cortex, which is important for emotion control, and the connection between the orbitofrontal cortex and the limbic system. So this network of emotion control is smaller, and they also have a smaller network in the inferior frontal cortex, which is important for cognitive functions, which we've seen before, and the connection to parietal areas. So this is an attention network. And this could, of course, explain why people with child abuse have the PTSD, anxiety, depression, so they have emotional problems, but they also have poorer, lower IQ and poorer performance in school, in attention, and other tasks. And this is directly related to the severity or the duration of abuse. So in conclusion, the brain is extremely plastic. The environment, like training functions or negative events, can change the brain, and brain abnormalities like neurological abnormalities can change behavior. So there is a very plastic and smooth bi-directional pathway between the brain and behavior. And that, of course, means that brain abnormalities, which we see in psychiatry, or in ADHD in this case, can be changed. They're modifiable. So we can change the behavior, we can give behavioral treatment, cognitive training, or meditation, and that will lead to brain changes. But we can also change the brain directly. And that's, of course, what we try to do with brain modulation therapies. So I will talk about two modern brain therapies. One is fMRI neurofeedback. So this is a method where you teach the child to increase activity of a particular area via neurofeedback, which is an active neurotherapy. And you can also change brain regions with brain stimulation, electrical, non-invasive, very small brain electrical stimulation. And this is, of course, more passive. But still, brain stimulation has been shown to lead to synaptic changes and neuroplastic changes. And you can combine it with cognitive training, where you get a stronger effect if you combine it with cognitive training. So in neurofeedback is based on very simple operant conditioning. So the child has to play a computer game, not with the button box as you normally would do, but he lies in the MRI scanner and he has to play this computer game with his brain activity. So we tell the child enhance the activity of this, say, the right frontal cortex, and the child, of course, has no idea how to do that. So he uses trial and error. He tries all sorts of things. We say you can focus on the rocketeer, or you can do other things, and children have all sorts of techniques which they often aren't even conscious. But every time the child manages to enhance the activity of this area, this is recorded in real time, and a computer is connected to the video game, in this case, the Rocketeer. So when he enhances the infrafrontal activation, the Rocketeer will go up into the sky. And of course, the child wants to continue playing. And when he realizes that he actually managed to move the Rocketeer, he will do it again. So this is how the child or the adult can learn in a very playful way to increase the activity of his brain. And healthy adults can do this in 10 minutes. And of course, we wanted to see whether ADHD children can also do this. And this was a PhD project by Ana Lucia Alegria and Melanie Wolf, helped with the analysis, and also Helen Brinson. And what we did in this study is we had 31 ADHD adolescents, and one group had to learn to increase the activity of the right infrafrontal cortex, and another group had to increase the activity of another area. And they had to do this over 11 runs of 4 hours, over 4 hours of MRI scans. And then we wanted to see whether this would lead to improved behavior, whether it would lead to better performance on those self-control tasks or attention tasks. We also wanted to see whether the activation in the brain during an inhibition task, where usually ADHD children have reduced infrafrontal activation, as I showed you, whether that would be increased after the training compared to before the training. And then, of course, we looked at side effects, and we also want to see long-term effects. So in the original study, we used the rocket. In our current study, we use the Rocketeer, and I show you this because I find it's more exciting. So this is the Rocketeer. So every time the child enhances the activity of the right infrafrontal cortex, this Rocketeer goes up into the sky, and then he sees some spaceships and things happen. And if he decreases the activity of the right infrafrontal cortex, then the Rocketeer goes down, and the aim is to reach a space station at the end. So this is fun, and it's actually feels like magic if you do it to move a computer game with your brain without any buttons. It really is quite an experience. So what we found is that ADHD children, and this was really the first study in children, it was also the first study in ADHD children who have problems with self-regulation, so we weren't even sure whether they can do it. But we found that children with ADHD can do it. So they increased the activity of the right infrafrontal cortex, and they did this after 8 runs. So healthy adults can do it after 4 runs. So ADHD children need twice as much the time, but they can do it. So you can see in the infrafrontal group, there's increased learning, the increased activity after 8 runs in these regions. Now, the control group who had to enhance another area in the brain, they also increased their region. So both managed to self-regulate their own region. And when we looked at the behavior, we found that both groups improved in ADHD symptoms. And in a way, we had 2 active groups, both regulated their brains, although it was different regions. But what was interesting at the follow-up at 11 months, we found that only the infrafrontal group improved in their symptoms even more. So they had 26% reduction, which is a very large effect size, which is similar to the effect size we see in medication studies. So the fact that this was more pronounced after 11 months than directly after the treatment speaks in favor of some longer term effect, a neuroplastic effect. So it may have changed the brain in a longer term manner. And this is what people observe with EEG neurofeedback as well. So when we looked at the activation during the inhibition task, where normally ADHD children do not activate this region, so you can also see here before the treatment, the ADHD patients do not activate the right infrafrontal cortex. So then we gave them the task to do after the treatment, and after they learn to upregulate this region, this area is now activated doing this self-control task. And this is again very similar to what I showed you. Stimulant medication enhances activity of this region, and neurofeedback of this region also enhances the activity of this region, but without the side effects. Now we wanted to also look at whether when you teach people to upregulate one single area, whether you can change entire networks, because we know the brain works in networks, and the infrafrontal cortex is connected to the basal ganglia, it's connected to other areas. So we wanted to see whether after the treatment of increasing infrafrontal cortex, whether this would have led to increased activation in other regions. And we did indeed find that there was increased connectivity between the infrafrontal cortex and the basal ganglia. So an entire frontostriatal network was increased after the treatment, and that was related to better symptoms. And we had an unexpected finding, but even more interesting, because we found the posterior cingulate was now decreased in connectivity, so it was better anticorrelated with the inferior frontal cortex. And I've showed you before that this is related to mind wandering, and the more you activate frontal areas, the more you switch off your mind wandering. So by training children to increase the frontal region, we are indirectly trained them to decrease the mind wandering regions, which is of course a good thing, and that was related to better impulsiveness and less inattention. So this is important because it means that if we want to change entire networks, we do not really need to change the networks. We can just change the frontal part of the network, and with all networks, the frontal part is always the CEO of the network, the boss of the network. So you just change the frontal part, and with that you change other networks. So you can change entire networks. So does fMRI neurofeedback work in ADHD? Yes, it's possible. And as I said, that was the first study in children, and especially children who have self-regulation problems. So children with ADHD can self-regulate the right frontal cortex. And we found, especially at the follow-up, there was a very good effect only in the infrafrontal group of improving in ADHD symptoms, although we found improvement in both groups after the treatment. We found the infrafrontal group also improved in sustained attention, but not in other tasks. And as I showed you, they had better activation in the infrafrontal cortex after compared to before the treatment, and they had changes in networks. And we found no side effects or adverse effects. So it's very safe. And of course, this is an advantage over stimulant treatment, for example. And because the findings were promising, we decided we needed to, of course, replicate the findings and do another study. And we wanted to include a placebo condition, which we call sham neurofeedback. So this is fake neurofeedback. And we've just finished a large study in 100 ADHD children, where we included a control condition where the controls got feedback from another person. So this is like fake feedback to control for the placebo effect. And we are just analyzing data. Unfortunately, I don't have the findings yet. So with respect to brain stimulation, I will tell you about the 3 stimulation techniques which have been used in ADHD: TMS, TDCS, and TNS, and I'll explain you what this is. So TMS is inducing an electromagnetic current to the brain, which leads to increased activity of underlying regions. And you can, of course, stimulate different areas. And most studies in ADHD have stimulated the dorsolateral prefrontal cortex. And it does hurt a little bit, so that's why most studies have done it in adults with ADHD. 2 studies found improvement, but 1 study didn't have a placebo condition. The later studies, which tested larger number of patients, 26 in larger number of sessions, like 20 sessions, they found no effect. So in the current evidence, there is not, in the current state of the art, there is not a lot of evidence that TMS of the dorsal prefrontal cortex is promising for improving ADHD symptoms. Now, TDCS is more child-friendly because it doesn't really hurt. You can hardly notice. I mean, some devices you don't notice the stimulation. And it's a very, very simple method, which has actually been around for a long time, but only recently it has been refurbished for psychiatry. And it consists in the application of an electrical current, the R-nodal electrode. It's very small. In children use 1 myoampere, in adults 2, usually for 20-30 minutes. And the R-nodal electrode leads to increased neuronal excitability on the region where you place it to, and the cathodal electrode leads to decreased neuronal excitability. So you can modify the brain activity with this method. And the advantage is it's very cheap. It's thought to be relatively safe, It has very minimal side effects, like a bit of reddening under the area or maybe a bit of a headache, but it goes away quite quickly. And it has been shown to increase the synaptic plasticity. There's also some studies have shown that improvement on cognitive function can last up to 1 year in some patients and in healthy controls. So there's evidence for longer term neuroplastic effects, which is of course what we are after. And it has been shown when you combine it with cognitive training, you get an increased effect, because you, depending which area you want to stimulate, you can also activate this area with cognitive training. And then you give the brain an extra push, so to speak, with the stimulation. So you combine it, and patients with ADHD may need this extra push because cognitive training alone hasn't shown to work very well. So we did a meta-analysis which Sam Westwood conducted. It was a postdoc in my lab, and what he did is we looked at all the studies, where 12 studies were found, and as you can see, most studies stimulated the dorsolateral prefrontal cortex, and they used 1 to 5 maximum sessions, so it's not a lot of sessions. Only 2 studies looked at clinical symptoms, and they found that it improved inattention, but not impulsiveness or hyperactivity. But most studies looked at cognitive functions, so they looked at tasks of inhibition, of working memory, attention, reaction time, and the green ones found an effect, and the non-highlighted one didn't find an effect. So you can see most studies found an effect on some tasks, but not others. So it was very mixed evidence, and that's why we did this meta-analysis, and this is Sam Westwood who did this study. And what he found is there was only a trend level effects on inhibition and processing speed. So it increased the speed or improved inhibition, but very small effect. It was not significant, and a very small effect size. And we found no effect on attention. Of course, that doesn't necessarily mean it doesn't work, but it does, at least there is not a lot of evidence that at least 1 to 5 sessions work. We don't know about more sessions. We also don't know about other areas, and we don't know what happens when you combine it with cognitive training. But at the current state of research, there is no convincing evidence that brain stimulation of the DLPFC is a good treatment for ADHD symptoms or cognition. So we also wanted to do our own study, and again, this was done by Sam Westwood, and we looked at we wanted to stimulate the right infrafrontal cortex together with playing some computer games, and they had to do this over a lot of sessions, 15 sessions over 3 weeks. They came in every day, Monday to Friday, and got 20 minutes of this stimulation, and then they had to play some video games. And I think the tone doesn't work, but these are sort of child-friendly video games. Where, you know, for example, you have to remember all the hands lifted by the pirates, which is a working memory task, or you have to sort some elements, but in other tasks you have to inhibit something, or you have to pay selective attention. And the better you get in the task, the more difficult the task becomes. So this is cognitive training on a tablet, which is very fun, combined with the stimulation. So what we found is that both groups, the real group and the sham group, they're both improved in symptoms and in cognition after the treatment and at the follow-up, but we didn't find that the real stimulation was better than the fake stimulation. If anything, the real stimulation was actually associated with less reduction in ADHD symptoms, and we found absolutely no differences also in the cognitive performance between the 2 groups. So, of course, this means that the stimulation didn't improve, didn't work. The fact that there was an improvement in both groups, of course, could mean that the cognitive training had an effect, because both groups got cognitive training with real stimulation or with fake stimulation. It could be a placebo effect, and it could also be a practice effect, especially in the cognitive task, of course, where you do the task 3 times, and you're of course better the 3rd time you do it than the 1st time you do it. We found no side effects, and we found very mild adverse effects. So in conclusion, the treatment is very safe, but unfortunately it didn't work. So our meta-analysis, which mostly stimulated DLBFC, and our study of stimulation of right infrafrontal cortex combined with cognitive training, both of them do not support the use of TDCS in ADHD at the current state. Now, the reason why this is very important, because there are already many clinicians in the UK and elsewhere who use brain stimulation as a treatment for ADHD, and I think at the current moment this is, in my view, not ethical, and that's why research is so important. We need to really show with research that there is a clear effect in randomized controlled trials, and if there is no effect, then this isn't really indicated at the moment. So I think it's not the final word, because far more studies are needed, which I will discuss a bit later. But I want to just mention to you the last neurotherapy, which is already FDA approved for ADHD since last year, 2019. And this is a very interesting stimulation, which stimulates the trigeminal nerve here on the forehead. And you can use it in the night. And the only reason it's done in the night is because you have to stimulate for 8 hours. And of course, you don't want to run around with some cables. So you just use it in the night. So you have this little plaster over your forehead, and you have a battery which has to, stimulates this with 2 to 4 milliampere, depending on how comfortable it is for the patients. And it can be done in children, as you see here. It's not very disturbing. You can have it under your pillow. And what it does, it stimulates the trigeminal nerve, which goes into the brainstem. And the brainstem here consists, among other things, of the locus ceruleus, which is very important for attention and arousal. And it sends neurotransmitters like noradrenaline to the cortex and to basal ganglia regions and the thalamus. So this is a way, in a way, an indirect way to stimulate the frontal lobe bottom up. So you use the brainstem, which then sends signals to the frontal lobe and other regions in the brain, also the cerebellum here. So this treatment is promising, and imaging studies have shown that trigeminal nerve stimulation indeed does increase the activity in frontal areas, in basal ganglia regions, and parietal areas, which are exactly the regions which are underactivated in ADHD. And it can also enhance some neurotransmitters like dopamine and noradrenaline, which are also typically enhanced with stimulant medication. And it enhances the arousal system, which is of course a key pathology in ADHD. Arousal and attention are impaired in ADHD. So the FDA approval was based on this study done in the USA, where they tested children between 8 and 12 years. So they got the treatment. One group got the real treatment, another group got the sham treatment, and then they measured also EEG before and after. And what they found is the treatment really improved ADHD symptoms with a sort of medium effect size. So this is quite good. It's like second-line treatment, pharmacological treatment for ADHD, very similar. And they found indeed in EEG that this treatment increased the activity of the right frontal region, which is called a key area of impairment for ADHD. And it had relatively mild side effects. So it's very promising, and here you can see the reduction in symptoms. And because it's promising, we were lucky enough to get funding from the NIHR, where next year we start a new study where we want to replicate it, because in science, one study I think is never enough. You need to replicate the study, you need to do it in a larger group, in a multi-center study, so we're using different centers. And we want to also look whether the effect persists 6 months later, because of course we are interested in whether this has a neuroplastic effect and longer term effect, which would make it superior to stimulant medication. And we're also looking at the effects on the brain, by using fMRI, which is more precise than EEG, to see what does it exactly do, which areas does it increase in ADHD patients. So to conclude, neurotherapies, I think, have a potential. We know now that ADHD is a brain-based disorder. There are areas which are not functioning well in ADHD, and we have very good targets from 3 decades of neuroimaging research of which areas would make sense to change or to modify or reverse the abnormalities if possible. They have relatively minimal side effects compared to medication. And as I said, the most interesting thing really is that they may have longer term effects, which drugs cannot offer. However, I mean, this is very much in its infancy. There are very few studies. We need far more studies. And if you think of medication research, in medication research, we spend like 60 years. People spend 60 years trying to find out which dose is the best dose for which weight of which ADHD patients, on which comorbid conditions, are best for improving ADHD with stimulant medication. So there have been 60 years of research on medication, on finding the optimal dose and so on. In brain therapies, we haven't had any of this. So we don't know anything about optimal protocols. We don't know what the best frequency is. So we, for example, use the random number of 15 runs of neurofeedback, but we have no idea. It could be that 5 runs are better. Maybe you need 30 runs, and no one knows really. The same with stimulation amplitude. In adults, it has been shown that 2 milliampere is a good amplitude. But in children with ADHD, nobody knows what's the best amplitude. And most people simply say for children, you need half the amplitude. But it may be too low. So for example, for the adolescents we tested, maybe the 1 milliampere was too small, and that's why it didn't work. Again, we also don't know what's the best region. We need to try out all sorts of different areas. Maybe the parietal lobe is a good region to stimulate. We also don't know whether there are brain saturation effects. Is there a plateau? And there is likely to be a plateau. And we know from stimulation studies that if you overstimulate a region, you actually get an impairment of the function, which is mediated by the region. So it doesn't go endless. So if you already have an optimal activation in this area, and then you stimulate this area over the top, you may actually get a negative effect. So all this needs to be investigated. It has also been shown that we stimulate one particular area, you may actually downregulate the neighboring region. And this has also been shown in fMRI, and it's called the blood flow steal effect. If you increase one region, it steals blood flow from a neighboring region or from a region in the other side of the hemisphere, because there is interhemispheric inhibition. So all this needs to be better understood, because if you stimulate one area and then you accidentally down-regulate another region, you may actually impair another function which you didn't want to modify. So this is, of course, needs to be investigated, because it could be dangerous potentially. We don't know anything about longer-term effects, so we've tested, as I said, 6 months usually, or a few months. But what about if it works after a year? Do you then need to top it up every year, every 2 years? How long does it last? No one knows. And I think the most important thing is, of course, individualized treatment. It is likely that different children have different we know that different children have different abnormalities in different regions. Some children have more emotional problems, they may have more limbic problems. Other children have more attention problems, so they have more dorsal prefrontal abnormalities. Others have more self-control, they have more infrafrontal abnormalities. And different children may benefit from medication. Other children may not respond to medication. Maybe for them, brain stimulation is better. And we also know that only 50% learn neurofeedback. There are children who cannot learn, and there are also adults who cannot learn neurofeedback. Not everybody learns neurofeedback. So we need to find out which children learn neurofeedback and which don't, and why. And as I said, we also, of course, different children may benefit from different number of sessions or different amplitude. So I hope I made it clear that this is very, very new, a field which is very new, and far more research is needed to have some really clear insight and to make a conclusion of saying this works or this doesn't work in ADHD. And I thank you very much for your attention. And I'm very happy to welcome questions. And even if you're too shy to ask a question, you can email me here on that email. I'm happy to answer any questions later on. Thank you.
Thank you so much, Katja.
Pleasure.
Thank you so much. That was an amazing talk. I mean, there was just so much within that. Really, really fascinating results. And also, as people have commented in the chat, really good to see the kind of the honesty when things don't work as well. And I'm just particularly encouraged that maybe there's hope for me that I will learn to juggle someday. Because it's always defeated me. We've got a lot of questions in the chat, so it's really great that you are happy to answer via email as well. I'm hoping, is it okay if we carry on till about 10 past? I'm not seeing anybody shaking their heads virtually at me yet, so they can just stop me if they do. So I'm going to just basically go with we'll get through as many of the questions as we can that had the highest number of likes. So the first relates to the study you were talking about on meditation, and is the meditation results seem extraordinary. How long did people meditate for every day, and was there a follow-up after the 5 years to see if the change in the brain had remained?
Yeah, no, there was no follow-up, and it wasn't all of them 4 or 5 years. Some had 20 years, some had 25 years. So it was a minimum. We put the minimum to 5 years, but on average, most people had more than 5 years to 10 years or so on. And now I forgot the first question.
Yeah, just how long people had meditated for every day.
Yeah, usually on average, I think it was at least an hour per day or half an hour per, something like that, 45 minutes per day. So these were people who had meditated regularly every day, usually. Yeah.
Thank you very much. And then the next most popular question, how widely available is neurofeedback treatment?
Yes, I mean, in Germany, for example, you can get it on the insurance already, but that's EEG neurofeedback. And meta-analysis on EEG neurofeedback have shown a very, very small effect and not even significant in properly blinded studies. But that doesn't mean it doesn't work at all, because there is evidence it works for some children and not for others. So in the UK, I think it's a bit more difficult to, but I think some clinicians offer EEG neurofeedback. You have to find a private practitioner who offers this treatment. Yeah.
Thanks very much. And then the next question, could any of these brain changes, I think this was quite an early question, could any of these brain changes be due to comorbid disorder solely, but then a diagnosis only of ADHD?
Yes. Typically, many imaging studies, I mean, all our imaging studies, we always excluded all comorbid conditions, with the exception of conduct disorder. So many of this, most people haven't excluded conduct disorder because they're so closely correlated with ADHD. So this is a good question, because conduct disorder, I think, is confounding the imaging literature.
Thanks. And then I'm going to take the next two most popular questions together, because I think we can ask you to reflect on both of them. So one relates to the strategies that people can employ in the workplace or at school to help people who have ADHD. And the other related to that is the fact that obviously people that, as you said at the beginning, people do seem to still equate some ADHD traits, you know, with those kind of historical associations of poor character. So how do we combat that outdated view? So I suppose how do we try to combat the stigma of ADHD?
Yes.
And also, what kind of strategies can we put in place to support people who do have ADHD, you know, either within the workplace or within education?
Yes. Well, with the second one, the stigma of ADHD, I think the best way to combat that is by information, you know, informing the public through the media that this, you know, that this is a brain disorder and it is not just a case of naughty children. With regards to the first question, yeah, I mean, I'm not a clinician, but so not really my area, but you know, it's people use ADHD patients use techniques. For example, having a desk where there's absolutely nothing on the desk, so you have no distractions. There are, of course, treatments, cognitive behavioral therapies to improve time management, self-organization skills, and so on. And of course, showing a bit more tolerance at school and being aware of the problems these children have. If you're a teacher, for example, is quite important, and giving them more structure and a bit more, more structure than you would give another child. It has been shown that structure in daily life helps.
Thanks, that's great. And then actually, I think this relates to the point you just made a moment ago about the treatment being available in Germany. So we have a question about whether neurofeedback is possible with EEG or MEG, or is there not enough signal to noise?
Or whether it's possible.
Yeah.
Yes. EEG neurofeedback is possible, and it has been done. It's been tested for over 40 years, so this has been around for a long time. But as I said, the evidence on EEG neurofeedback is mixed, and the latest meta-analysis, which colleagues of mine have done here at the Institute of Psychiatry, like Edmund Sonoga-Bach, they didn't find much evidence, that it has a very small effect. With MEG, you can also do neurofeedback with MEG, and it has been, it is actually, I know that in the NIMH they're trying to do that, but I haven't really seen a study yet. But it's a good idea. But what I think the best, in my opinion, is NIRS neurofeedback. So NIRS is optical imaging, and that is done a lot in Tübingen, in Germany again, and this is very promising, and they have found very good effects like we have, and then now they're doing a large trial, so we will see what they find of hundreds of children. But NIRS is much cheaper than fMRI, and that's something you could buy for clinics. It costs about 20,000, the cheapest, and it's a good method for neurofeedback, but you can only give feedback of cortical areas, while with fMRI you could use subcortical. If you wanted to give neurofeedback of the frontal lobe, then NIRS would be good and sufficient, and it's very robust against movement, so which is very good for ADHD children. Yeah.
Thank you. You've been fantastically efficient at answering these questions. I think we've got through nearly all of the ones that we managed to publish. So the last question then before we finish is around the gender difference that you mentioned early on. So if it's true that in children, girls have lower rates and less severe ADHD than boys, is it possible to see this through MRI scans as well at all?
Yes, it is possible. And in fact, there is a study which showed that the differences were more pronounced in males and not in females. But females have not necessarily less severe, they're less picked up. It shows differently. It's more the inattention than the hyperactivity. So it's less noticeable in the classroom. But they can have severe inattention problems and impulsiveness problems, but it's less obvious because they don't run around as much as the boys. But the evidence, there are very few studies in girls, so that's why I don't want to say too much. As I said, one study found not much in girls, but it doesn't mean it's not there. I think people haven't studied girls, so most studies have been conducted in males with ADHD.
Thank you so much. So I think I'm going to draw things to a close now. It has been a really great way, as I say, to round off what's been a fantastic lecture series. So thank you so much, Katja. Sorry
that I overran. I didn't realize.
No, well, it didn't feel that long. It really didn't. As I say, it was absolutely fascinating. So thank you so much. Thank you also for offering to answer any questions that people have over email as well, which I think will be hugely important. So thank you all so much. Thank you also to the audience, to our students and staff members who've been joining us for these lectures. It's been really great to see the turnout. It's been really great to see the engagement and the questions coming through too. We really hope that you've enjoyed the lecture series, that it's provided something of a distraction a couple of times a week as we've kind of gone through these very, very strange times. So as I say, thank you once again to Katja, to all of our other speakers, all of our other chairs, and to everybody who has made this happen behind the scenes. I wish you a very restful break, everybody. For those of you who are celebrating Christmas, I wish you a very happy Christmas as well. And we look forward to seeing you more in 2021 for more events yet to be decided. Thanks very much.
Thanks.